Imagine a jagged saw blade inside your patient's wrist, just slowly and silently cutting through their tendons one by one until their fingers simply drop, completely unable to extend.
Yeah, it's a brutal visual. But if you are a resident preparing for your board exams, like the FRCS in plastic surgery, that visual is your starting point today.
Exactly. We are skipping the pleasantries. This deep dive is a rapid-fire, high-yield revision session focused entirely on the upper limb manifestations of rheumatoid arthritis.
Right. Our mission today is to lock down the pathophysiology, the clinical presentations, and, the strict surgical management principles you are required to know to pass the boards.
We're treating this like a surgical campaign. I mean, we need to understand the enemy's biology before we even think about surgical tactics.
Definitely. You can't just jump in with a scalpel.
Right, so let's start at that biological level. Before you operate, you have to understand the microscopic war zone destroying the joint. So define the ultimate systemic drivers of RRA that lead to these severe hand deformities we see.
Well, fundamentally, rheumatoid arthritis is driven by persistent synovitis and systemic inflammation. Genetically, examiners want you to identify point mutations in the PTPN22 and HLA genes.
Just those two?
Primarily, yeah. Those are the markers with actual pathogenic implications. They make up about 50% of the risk profile. But on the environmental side, smoking is the massive red flag.
Oh, wow. Does it have that much of an impact?
Oh, absolutely.
Yeah.
If your patient smokes, they literally double their risk of developing the disease.
Right. Okay, so I want to zoom in on the cellular level. I know there's a dual cell attack happening in the joint space, but how does that mechanism actually dismantle the cartilage in the bone?
So you have two distinct types of rogue cells inside the joint capsule. First, there are macrophage-like synoviocytes.
Okay.
These cells act as factories, overproducing tumor necrosis factor, or TNF, alongside interleukins IL-1 and IL-6. This chemical soup is what drives that aggressive hot synovitis inflaming the joint.
Right, the inflammation. And the second type?
Second, you have fibroblasts-like synoviocytes. And these aren't just releasing chemicals, they physically invade the articular cartilage. They form this destructive tissue called pannus that essentially eats the joint from the inside out.
Like a tumor, almost. Diagnostically, we know that between 50 to 80% of RA patients will test positive for rheumatoid factor, or RF, or anti-citrullinated protein antibody, which is ACPA.
Right.
I'm putting myself in the shoes of a reconstructive surgeon here. Why should I care if my patient has ACPA over just having RF?
Well, RF is simply an IgM or IgA autoantibody directed against the FNC portion of IgG. It forms immune complexes that trigger the complement cascade, but, it isn't exclusively tied to severe bone destruction.
But ACPA is?
ACPA is a completely different beast. Most ACPA-positive patients also test positive for RF, but ACPA is a significantly more specific and sensitive diagnostic marker.
Okay, that's good for the rheumatologist, but for the surgeon?
More importantly for you as a surgeon, high ACPA titers are a direct predictor of poor prognostic features, specifically severe joint destruction.
Oh, I see.
Yeah, if you are planning a complex, long-term campaign of joint reconstruction, high ACPA warns you that the bone stock you're drilling into is going to degrade aggressively.
Right, you want to know if the foundation is crumbling before you try to rebuild a house.
Yes, exactly.
So to even establish that baseline diagnosis, we have to know the 2010 and Creeler classification criteria. This is a point system where a score of 6 or more confirms RA.
Yep, 6 out of 10.
Right, and it relies on 4 pillars: joint involvement, serology, acute phase reactants, and symptom duration. But I don't just want to memorize a table. Let's look at the logic.
Let's hear.
You get up to 5 points, which is the maximum single category score for joint involvement, specifically if more than 10 joints are involved, with at least one being a small joint. Why the obsession with small joints?
Because RA has a distinct predilection for the small synovial joints of the hands and feet early in the disease process. I mean, osteoarthritis might hit the large weight-bearing joints, but RA attacks the MCP and PIP joints first.
Got it. And the rest of the criteria follow a similar clinical logic, right?
Yeah, you get up to 3 points for a high positive RF or ACPA titer, reflecting that aggressive immune response we just discussed. You get 1 point for abnormal acute phase reactants like CRP or ESR, proving systemic inflammation.
Right, the hot joints.
And finally, you get 1 point if symptoms have lasted 6 weeks or more.
Wait, why 6 weeks? What's the physiological significance of that exact cutoff?
It rules out self-limiting viral arthropathies. Many viruses can cause severe polyarticular joint pain that mimics RA perfectly, but they burn out within a month.
Oh, interesting.
Yeah, so if the synovitis is still raging at 6 weeks, the immune system is locked into an autoimmune loop.
That makes total sense.
Yeah.
This systemic nature of the disease brings up another hurdle, though. Because the immune system is circulating everywhere, surgical patients rarely arrive with just hand problems.
Very true. They almost always have multi-organ involvement.
Let's break down the major extraarticular syndromes examiners love to test. What are the big ones?
You must know 3 key syndromes. First is Sjogren's syndrome, which presents as the triad of dry eyes, dry mouth, and RA. The immune system is essentially attacking the moisture-producing glands.
Right. And the second?
Second is Felty syndrome. This is RA combined with splenomegaly and neutropenia.
Because the spleen is trapping the white blood cells.
Exactly. The spleen enlarges as it traps them, leaving the patient immunocompromised. That's a critical detail when you're considering postoperative infection risks.
Absolutely. And the third syndrome?
Third is Kaplan syndrome, which is RA in combination with pneumoconiosis, presenting as large intrapulmonary nodules.
Okay, so before these patients ever see the inside of our operating rooms, they face a massive medical wall. How has modern medical management altered the surgical landscape? I mean, what non-operative therapies do we need to understand?
The first line of defense is disease-modifying anti-rheumatic drugs, the DMARDs. We're talking about methotrexate, sulfasalazine, and leflunomide.
And these actually stop the progression.
They do actually reduce progressive joint damage, but they require rigorous monitoring. Methotrexate, for example, carries severe risks like hepatotoxicity and interstitial lung disease.
And if the DRs fail to halt that pannus we talked about earlier?
Then rheumatologists escalate to biologics. These are engineered proteins that target the exact inflammatory pathways we mentioned earlier. Adalimumab blocks TNF-alpha, anakinra targets IL-1, tocilizumab blocks IL-6.
I notice you left steroids off that long-term list. Where do they fit in?
Steroids are strictly tactical, short-term weapons. Use them to control acute flare-ups or inject them directly into isolated, stubborn joints.
Because of the side effects.
Right. Their systemic risk profile, osteoporosis, skin thinning, immunosuppression is just too unfavorable. You cannot keep a patient on high-dose systemic steroids long-term without causing iatrogenic devastation.
That sets the stage beautifully. So when that medical management fails and the joints continue to erode, the surgical campaign begins. But the rules of engagement are ruthless here. I want to highlight the absolute contraindication to operating on a rheumatoid hand.
This is huge for the boards. The cardinal rule is this: you never operate on a pain-free hand with good function.
Never. Even if it looks terrible.
Never. Deformity alone, no matter how grotesque it looks on an X-ray or to the patient's family, is never an indication for surgery if the patient has adapted and maintains function.
Which brings us to the hierarchy of surgical indications. If a patient comes in with a destroyed wrist, severe ulnar drift, and they just hate how their hand looks, our priorities as surgeons have to be strictly ordered.
Absolutely strictly ordered.
Priority 1 is pain relief. Priority 2 is improvement of function. Priority 3 is prophylaxis to prevent further structural collapse. And dead last priority 4 is cosmesis.
If you violate that hierarchy, you will take a patient who has an ugly but functional hand, operate to make it look normal, and leave them with a beautiful hand that cannot grasp a cup of coffee.
That is the ultimate trap. And to avoid that trap, we look to Willie Soder's famous league table of operations.
Yes, a classic.
Suter created a brilliant surgeon's playbook of winners and losers in rheumatoid surgery. The winners are highly successful, durable procedures. We're talking about joint fusions, extensor synovectomies, Dirac procedure at the distal ulna, and MCPJ arthroplasty.
Notice what the winners have in common, though. Fusions permanently eliminate the synovial tissue in that joint and create a rigid, stable pillar. Synovectomies remove the destructive pannus before tendons rupture. They are definitive.
On the flip side, Suter's losers are procedures with poor long-term outcomes. These are soft tissue procedures for swan neck and boutonniere deformities and PIPJ arthroplasties. Why do these fail so predictably?
Well, because you are relying on degraded, diseased soft tissue to hold tension, the systemic disease simply eats through your delicate soft tissue repairs.
And the arthroplasties.
With PIPJ arthroplasty, the osteopenic bone stock often cannot support the implant. It just leads to subsidence or loosening.
Makes sense. Timing and staging are just as critical as picking the right procedure, too. The surgical campaign must start proximal and move distal.
Always. You assess and treat the shoulder and elbow first. If you perfectly reconstruct a hand, but the patient has a destroyed, painful shoulder, they still can't position that hand in space to use it.
Right. And you also have to assess the lower limbs.
Yes, definitely. If a patient relies on crutches because of destroyed knees or hips, you cannot perform complex, delicate upper limb reconstructions. The weight-bearing forces of a crutch will obliterate your MCPJ arthroplasty within weeks.
Wow. Yeah, you have to look at the whole patient. Let's move to the battlefield of the wrist. The classic deformity examiners demand you understand is Caput-Ulni syndrome. Break down the biomechanical collapse happening here.
So Caput-Ulni syndrome is a three-part anatomical disaster. First, the carpus subluxes volarly, slipping down and away from the ulna.
Okay, that's one.
Second, the extensor carpi ulnaris, the ECU tendon, subluxes volarly out of its groove. And third, the carpus supinates, rotating away from the ulnar head.
This gives us the famous piano key sign on clinical examination, right? Because the carpus has fallen away, the ulnar head is left completely unsupported and becomes incredibly prominent on the dorsum of the wrist.
Exactly. You can press it down with your thumb, and it springs right back up when you release pressure, exactly like a piano key.
So for surgical management, you have several reliable options from the winner's list. Doric's procedure involves excising the distal ulna entirely, removing that prominent bone.
Right. And you can then use a sling fashioned from the extensor retinaculum to support that volarly subluxed ECU tendon.
But what if it's a younger patient?
For younger patients where you want to preserve better grip mechanics and prevent ulnar stump instability, the Sauvé-Caponghi procedure is superior.
How does that work?
This involves fusing the distal radial ulnar joint, but segmentally resecting a small piece of the distal ulna just below the fusion to maintain forearm rotation.
And if the entire radiocarpal and midcarpal joints are destroyed and just excruciatingly painful, you escalate to a total wrist arthrodesis. Historically, this was done using a heavy Stanley pin inserted straight down through the head of the third metacarpal, across the carpus, and into the radius.
But examiners want you to know the biomechanical drawback of the Stanley pin. It forces you to fuse the wrist in absolute neutral.
And neutral is bad for grip.
Very bad. Fusing in neutral weakens the natural grip strength, which relies on slight extension. Plus, it makes future MCP joint replacements much more difficult to balance.
Right. So today, we rely on low-profile dorsal locking plates, which allow us to dial in about 10 to 50 degrees of functional extension. They also provide excellent screw purchase, even in soft, osteopenic rheumatoid bone.
Yeah, that's the gold standard now. Let's address the collateral damage caused by that collapsing wrist, though. The bony destruction directly threatens the extensor tendons passing over it.
This brings us back to the hook I mentioned at the start, the jagged saw blade. This is the Von Jackson lesion. As the ulnar head erodes, it creates a sharp, bony spike.
And the extensor tendons are stretched tight over this spike, moving back and forth with every finger motion. It methodically saws through them.
Walk us through the exact sequence of these tendon ruptures, because the pattern is highly predictable.
The ruptures happen strictly from ulnar to radial. The ECU is usually spared because, as we discussed in Caput-Ulni, it has already displaced safely volar, hiding below the saw blade.
So what goes first?
Therefore, the extensor digiti minimi, the EDM, is the first tendon to get cut. Clinically, the patient loses the ability to independently point their little finger.
And then?
From there, the common extensors, the EDC tendons, rupture sequentially, little, then ring, then middle, just marching toward the index finger.
Now, when you open that wrist, you can't just sew the two ends back together. Primary repair is impossible.
No, you cannot sew a rope back together that has been shredded into 1,000 fibers by a saw. The tendon ends are frayed, diseased, and retracted.
So what's the move?
You must perform tendon transfers, borrowing a functioning tendon to replace the lost one.
Let's trace the logic of these transfers based on the deficit. This is a prime rapid-fire board material. If one tendon is ruptured, usually the EDM, what's the move?
You transfer the distal stump of the EDM to the side of the intact ring finger common extensor.
Easy enough. What if two tendons are gone, the little and ring extensors?
You have two valid options. You can transfer both of those distal stumps to the middle finger extensor. Alternatively, you transfer the ring stump to the middle extensor, and you harvest the extensor indicis, the EI, to motor the little finger.
Okay, what if the saw blade has taken out three tendons? Little, ring, and middle.
Now you are running out of local dorsal options. You transfer the distal middle finger extensor to the intact index EDC. Then you have to borrow from the flexor side.
Which one?
You take the flexo digitorum superficialis, the FDS, of the middle finger, Route it through the interosseous membrane or around the wrist, and use it to motor the ring and little finger extensors.
Wow. And the absolute worst-case scenario, a complete wipeout. All extensor tendons are ruptured.
You need two strong motors for that. You take the FDS of the middle finger to motor the index and middle extensors. Then you take the FDS of the ring finger to motor the ring and little extensors. You route these radially around the wrist to the dorsum.
Wait, why route them radially instead of straight through the interosseous membrane?
Because routing them radially introduces a supinating and radially deviating force. This actually helps counteract the natural tendency of the rheumatoid hand to collapse into ulnar drift and pronation.
That is brilliant biomechanical strategy. Let's flip the hand over, though. The volar side has its own attrition hazards. What causes the classic flexor pollicis longus, or FPL, rupture?
The flexor equivalent of the von Jackson is the Mannerfelt lesion. This is a sharp, bony osteophyte that forms on the volar surface of the scaphoid.
And the tendon just saws over it.
Exactly. As the FPL glides over it during thumb flexion, it undergoes attrition and eventually snaps.
This sets up the most common trap examiners lay for residents. A rheumatoid patient presents in clinic with an inability to extend their fingers, a dropped finger presentation.
A classic scenario.
I want to try to logic through this. If a patient's fingers are dropped, my immediate thought is extensor tendon rupture from a von Jackson lesion.
Right, that is the most obvious answer, but you need a complete 4-point differential diagnosis, and you must know the clinical tests to distinguish them instantly. How do you confirm an extensor rupture?
I would look for the loss of the tenodesis effect. If I passively flex their wrist, the natural tension on intact extensors should cause the fingers to automatically rise into extension. If the fingers stay dead and dropped, the tendons are cut.
Correct.
But what if the tendons are intact? Could they have just slipped out of place?
Yes, that is number 2 on your differential. Ulnar subluxation of the extensor tendon over the MCP joint. The sagittal bands, which hold the tendon centralized, become stretched and destroyed by synovitis. The tendon simply slips volar to the axis of rotation of the MCP joint.
So because it dropped below the axis, the extensor tendon is now mechanically acting as a flexor. The patient cannot initiate extension from a flexed position.
Right. But if you passively lift their finger up for them, lifting the tendon back dorsal to the axis of rotation, they can hold it there.
Spot on. Okay, number 3 is a volar MCP joint dislocation. The defining clinical feature here is that the joint is rigidly locked. It is fixed and not passively correctable no matter how you manipulate the wrist or fingers.
Exactly. You can't force it up.
And number 4 has to be neurological. Posterior interosseous nerve, or PIN compression.
Correct. The rheumatoid synovitis at the radiohumeral joint in the elbow can actually compress the PIN. The patient loses active finger and thumb extension.
But the tenodesis effect is still there.
Crucially, yes. Because the tendons are perfectly intact, the tenodesis effect is completely preserved when you passively manipulate the wrist.
That is such a high-yield differential.
Yeah.
Let's move down the kinetic chain into the fingers. We mentioned earlier that deformity at the wrist cascades into the digits via the Z mechanism. I've seen Z mechanism in the textbooks, but visualize this for me. What is actually zigzagging?
Well, think of the hand as a linked mechanical system of intercalated bone segments under tension. If the carpus collapses and slides down the ulnar slope of the radius into radial deviation, the metacarpals follow.
Okay, so the wrist goes radial.
Right. And to keep the fingers pointing forward so the patient can still grab things, the proximal phalanges must compensate by angulating in the opposite direction at the MCP joints.
So the wrist deviates radially, and the MCP joints deviate ulnarly. It forms a literal Z shape.
Exactly. And at the MCP joint, the aggressive synovitis erodes the dorsal capsule, which is its thinnest, weakest point. The joint undergoes volar subluxation, and we see that extreme ulnar drift.
But ulnar drift isn't just caused by the Z mechanism. There is a whole confluence of forces driving those fingers ulnarly.
There are 6 major driving forces. First is the daily lateral pressure applied to the index finger by the thumb during key pinch. Second is intrinsic muscle tightness. And third is the unopposed pull of the abductor digiti minimi on the little finger.
Right, so that's already 3 mechanical disadvantages pulling everything ulnarly. What else?
Fourth, you have the natural anatomical ulnar inclination of the metacarpal heads. Fifth, the long flexor tendons enter the hand on the ulnar side of the wrist, exerting a natural bowstringing ulnar pull during heavy grip.
And the 6th is the Z mechanism.
Exactly. The 6th force is that compensatory radial deviation of the wrist, causing the Z collapse we just described.
As we move past the MCP joints, we hit the proximal interphalangeal joints. the PIPJs. You have to know the difference between a swan neck and a boutonniere deformity, and you must know the nail buff classification for treatment. Let's start with the swan neck deformity. PIPJ hyperextension combined with DIPJ flexion.
So the nail buff classification dictates your surgical path here. Type I is a flexible PIPJ deformity. You do not operate on a type I.
What do you do instead?
You treat it conservatively with silver ring splints that act as physical blocks to prevent hyperextension.
Okay, and type 2.
Type 2 is characterized by intrinsic tightness. The PIPJ's ability to flex depends entirely on the position of the MCPJ. If you hold the MCPJ in extension, the PIPJ cannot flex. The surgical treatment here is a lateral band mobilization and intrinsic release.
And types 3 and 4.
Those are fixed deformities stuck in hyperextension. Type 3 requires gentle manipulation, intrinsic release, and potentially a flexor tenodesis to hold the joint down.
And type 4 is the end of the line.
Yeah, type 4 involves severe radiographic joint destruction on the X-ray. You cannot save the joint surface, so you must perform a PIPJ arthrodesis.
Now contrast that with a boutonniere deformity. Boutonniere means buttonhole in French. Here, the posture is reversed. The PIPJ is in fixed flexion, and the DIPJ is stuck in extension.
The synovitis destroys the central slip of the extensor mechanism right at its insertion on the middle phalanx. Without that central tether, the lateral bands displace volarly. They drop below the axis of rotation of the PIP joint.
Just like we discussed with the slipped extensor tendons at the MCP joint. Once the lateral bands drop below the axis, they become powerful flexors.
Exactly. The head of the proximal phalanx literally pokes up through the buttonhole created between the separated lateral bands.
For this, we use the nail buff and Melander classification. Type I is a mild extensor lag of 10 to 15 degrees that is completely passively correctable.
We treat type I with extension night splinting and a dolphin or Fowler tenotomy. That involves surgically dividing the lateral bands just distal to the PIPJ over the middle phalanx, which stops their abnormal pull from forcing the DIPJ into rigid extension.
And type 2.
Type 2 is a moderate lag of 30 to 40 degrees, still passively correctable. This requires actual soft tissue reconstruction to shorten the attenuated central slip or mechanically centralize those dropped lateral bands back to the dorsum of the digit.
And type 3, I assume, is just a destroyed joint.
Right. Type 3 is a fixed flexion contracture with joint destruction. The only reliable option is an arthrodesis.
Finally, we cannot ignore the rheumatoid thumb. The thumb operates on the exact same anatomical mechanisms we just covered, but it dictates the functional grip strength of the entire hand. How do the finger deformities map onto the thumb's unique anatomy?
The mechanisms are perfectly analogous. You just shift the terminology. The thumb MCP joint acts like a finger PIP joint. The extensor pollicis brevis, the EPB, acts like the central slip. We use nail buff's classification for the thumb as well.
The most common presentation you will see is a nail buff type I thumb.
Yes. Type I is the boutonniere deformity of the thumb. The MCPJ falls into flexion, and the IPJ goes into hyperextension.
And where is the root of the problem?
The primary disease, the root of the collapse, is located right at the MCP joint. Because the MCP joint is the epicenter, it is treated highly successfully with a simple MCP joint arthrodesis. You fuse it, and the IP joint often corrects itself.
But what about the swan neck posture of the thumb?
That is nail buff type 3. The critical biomechanical distinction here is that type 3 is not driven by the MCP joint. It is predominantly driven by carpal-metacarpal joint, or CMCJ, disease at the base of the thumb.
So what's happening at the base?
The first metacarpal sublexes radially and dorsally off the trapezium. This causes a severe adduction contracture into the palm. To reach out and grab a large object, the patient is forced to hyperextend their MCP joint to compensate.
Ah, so it's a compensatory hyperextension.
Exactly. Because the root cause is at the base of the thumb, treating the MCP joint will fail. You must treat the CMC joint, typically with a trapeziectomy, to remove the diseased bone and release the contracture.
Oh, okay. We have traced this pathology from a genetic mutation through the inflammatory chemical soup, down the radius, across a collapsing wrist, and zigzagged right into the very tips of the fingers.
It is a massive topic.
It really is. And I want to leave you with a final thought to mull over. With the rapid advancement of the DRs and biologic therapies we discussed, we are seeing dramatically fewer classic rheumatoid hands than reconstructive surgeons did 30 years ago.
It's true. This severe multi-joint destruction that requires massive tendon transfers and total wrist fusions is becoming incredibly rare.
Right. So what happens to surgical training and board exams when these complex, severe deformities become purely historical textbook artifacts rather than clinical realities you routinely face in the operating room. Something to think about.
Definitely a paradigm shift.
Press follow on the show right now so you don't miss future revision deep dives, and rate the show if you learned something today. For those of you serious about your exams, get a premium subscription to listen to our Journal Club and Clinical Cases deep dives.
Highly recommend those for exam prep.
And before you get back to the textbooks, drop down into the comments right now and leave a comment or a question about the biomechanics of those extensor tendon transfers or the drop finger differential we covered today. Keep studying. We will see you next time.